Good evening, everyone. I want to thank the Delhi Neuro Oncology Group and Dr. Indu Bansal for having invited me for this talk on SRS and SRT in vestibular schwannomas. So over the next 15 to 20 minutes, I shall be talking about the evidence and the technology that surrounds the delivery of SRS and SRT in vestibular schwannomas. Coming to the evidence part of it, first of all, I'm talking about the growth patterns for vestibular schwannomas. And as you can see from the series of studies that have been displayed on the right side, the typical growth rate varies from 1 to 2 mm per year. However, there is a bit of variability there. There is a greater likelihood of tumor growth if you have larger tumor size and presence of tinnitus at diagnosis. And there is a lesser likelihood of growth for intrametal tumors. There could be variable growth patterns in vestibular schwannomas, including spurts of growth, linear growth, exponential growth, stable size, and sometimes even decreasing size. So what are the treatment options for vestibular schwannomas? These could range from conservative management, including serial radiological follow-up or radiation or surgery. And the combinations of treatment that are possible are actually around 5. Observation followed by radiosurgery of tumor growth, observation followed by microsurgery of tumor growth, immediate radiosurgery, and immediate surgery. So large tumors that are compressing the brainstem or causing mass effect surgery is generally recommended because it gives instant relief of the mass effect. For small to medium-sized vestibular schwannomas, which are less than 3 centimeters, there could be various options, including observation, surgery, and radiation. And the Coos grading system ranging from 1 to 4, as you can see in the figure on the right side, is generally used. So grade 1 would be a small intracanalicular tumor, and grade 4 would be a large tumor with brainstem and cranial nerve displacement. ENO guideline, European Association of Neuro-Oncology, also say more or less the same thing, giving you the options for spontaneous vestibular schwannomas, which are small and asymptomatic, or slightly larger with complete hearing loss, and then going on to spontaneous with large size and brainstem compression, whereas I said surgery is option number 1. But they have considered surgery inferior to combination surgery and stereotactic radiosurgery. And I shall be talking about this hybrid technique later on. So NF2 lesions, again, option includes surgery and or SRS and or bevacizumab and or SRT, depending on the situation. So as we have realized till now, SRS and surgery are two very prominent modalities that are used in vestibular schwannomas. And these are the broad differences between the two treatment modalities, as you can see. And frankly, there has been no head-to-head randomized comparison which can tell us which is more beneficial and which is has an edge in a particular situation and which has more survival benefit. These are broadly the tumor recurrence rates that you get from literature. For example, SRS typically 1 to 10% is the 5-year tumor recurrence rate with gamma knife. With surgery, gross total resection 3.8%, near total resection around 9.4%, and it increases. The tumor recurrence rate increases to 27.6% for subtotal resection. So the more the volume that is left behind, the higher the chance of recurrence of disease. And similarly, you can see the differences in the pattern for hearing preservation rate, facial nerve preservation rate, trigeminal preservation rate, and so on. There is a slight 0.5% chance of mortality after surgery. I'm sure it's going down by the day as technology is improving. So factors influencing preservation of serviceable hearing post-surgery include tumor size. So if there is a small tumor size, preservation of hearing is more possible. Presence of a distal internal auditory canal CSF fluid fundal cap. And if you have a good preoperative hearing, that again increases the chances of preservation of serviceable hearing. Coming to the role of fractionated SRT in acoustic neuromas, I'm presenting this study which was published in the Green Journal in 2013. 158 acoustic neuromas, a dose of 50 gray was used, and the median tumor volume was around 2.4 ml. with a median follow-up duration of around 5 years. You had radiation-induced trigeminal nerve impairments around 3.2%, grade 2 facial neuropathy is 2.5%, and you had a local control tumor control rate of around 99% at 3 years and 95.2% at 7 years, which is quite good. And the preservation for grade 1 and grade 2 Gardner-Robertson scale was around 54%. This is the Gardner-Robertson scale of hearing function, grade 1, which is the best, and grade 5, which is the worst. And then I'm talking about some series which gave single fraction of treatment, single fraction radiosurgery. I'm presenting this series from Fleckinger, 216 patients previously untreated, gamma knife between 1992 and 2000 with a dose of 12 to 13 gray, the marginal tumor dose with a median follow-up of around 6 years, resection-free tumor control around 98%, unchanged trigeminal nerve function around 94%, preservation of any testable hearing around 85%, which is quite good. There have also been series, for example, this series from Norway, which has compared gamma knife radiosurgery with just conservative management, which is just kind of a follow-up without doing anything. So this is a series, although it has been collected prospectively, but definitely this is not a randomized study by any means. So with a median follow-up of around 55 months, there was a significant reduction in tumor volume over time in the gamma knife radiosurgery group. And also, as you can see in the right side of this slide, the need for secondary treatment was much less for the gamma knife arm as compared to the no treatment. So the no treatment arm required more, they had a more chance of requiring secondary treatment as compared to the gamma knife arm. Again, this was a meta-analysis published in 2010 in Neuro-Oncology of around 3,600 patients who underwent single fraction radiosurgery, tumor control rate of 91%, facial neuropathy rate of 7.1%, and useful preservation, hearing preservation rate of around 59% or so. Over the years, the trend that has been observed is declining radiosurgery doses. So we now know that doses of around 13 gray, something ranging between 12 to 14 gray are good enough for control of acoustic neuromas. So the International Stereotactic Radiosurgery Society, or the ISRS practice guideline, says that targets up to 3 centimeter in maximal diameter can be taken up for SRS, or small vestibular schwannomas without significant mass effect like Coues grade 1 tumors. Again, for these, the options are observation and SRS, or growing small to moderate size vestibular schwannomas without significant mass effect. Coues grade 1 to 3 are also good candidates for stereotactic radiosurgery. The other indications for stereotactic radiosurgery include vestibular schwannomas, which are recurrent ones, which have recurred after surgery, because here now the risk of damage with the repeat surgery becomes quite high, and that's why radiosurgery has a slight edge in such situations. SRS, as you can see, there are around 5 prospective studies. I'm not saying randomized trials, but 5 prospective studies that have supported the view that SRS is probably superior to microsurgery for patients with vestibular schwannomas less than 3 centimeter in terms of preserving facial nerve and hearing function. Now, as most of us know, for SRS, we use either a cobalt-based gamma knife or a modern linear accelerator. Doses, as I said, from 11 to 14 gray, and fraction size ranging from single fraction in smaller tumors to 2 to 5 fraction in larger tumors. These are the OAR constraints. Of particular use is and importance is delineating the cochlea, and for single fraction, typically recommended to keep the cochlear mean dose less than 4 to 6 gray. As most of us would have experienced in our practice, some of our patients develop pseudo-progression after SRS in vestibular schwannomas. Now, this is a transient enlargement that occurs within 3 years of radiosurgery. It's observed in around 1/3 of the patients. It's related to the effect of SRS itself, but it's not a predictive of failure. Please note that. And it needs to be managed with clinical and radiological observation, and you need to have regular MRI scans. And that's how these patients are managed. Coming to NF2 with uni or bilateral vestibular schwannomas, I've already mentioned the management of these tumors in the guidelines. The challenges in these patients are the high incidence of the newly developing tumors, the fast tumor growth, early tumor regrowth, and lack of a cure, lack of a permanent cure. These are the challenges that we face in NF2 patients. I also want to take a minute and talk about hybrid approaches that are coming up for management of acoustic neuromas. Now, as we know, there is a direct relationship between tumor volume and functional volume. So far, for large vestibular schwannomas, there is a lower risk of recurrence after gross total resection, but there is a higher risk of facial nerve dysfunction and a lower risk of and lower rate of hearing preservation if we go ahead with some kind of a radical removal. So that is why what has come up now is partial resection, partial safe resection of the tumor followed by SRS to the residual area. And this approach has become increasingly popular, and you have quite a few series of this approach now giving very, very promising results. So essentially what is done is you have a large tumor, as you can see in this coronal plane, there's a brainstem here, there's a cochlea here, and then you do internal decompression of the tumor with guided by nerve stimulation. And this is the closure, the collapse of that area, and you have this residual, small residual thing, and you wait for a few more months. It's not that you resect and then you do immediate radiosurgery. You wait for 6 to 8 months, and then you get the final residual volume, and then you treat it with radiosurgery. And for this approach, again, as I said, quite a few series, and I've just picked up one Swiss study which had 32 consecutive patients, and what it found was that the mean residual volume was just 30% of the original volume, of the original pre-operative volume when the patient came up for radiosurgery. And then they gave around 12 gray median of radiosurgery, median follow-up of around 24 months. Following gamma knife radiosurgery, there was no new neurological deficit in these patients, and that was indeed promising. So I have covered more or less in the time constraint that I had the evidence part of acoustic neuromas. I'll just briefly now allude to the technology part. So as we know, in SRS, we have integration of modern imaging. We use much higher doses per fraction, much more number of beams, frequently non-coplanar beams, and so on and so forth. And all this, when it's combined, becomes SRS, multiple beams, different direction, high peak of dose and rapid fall off of dose. We began with invasive frames, moved to non-invasive frames, and then for most of our patients, now we are using frameless techniques, which gives us so much flexibility, whether it's the number of fractions, whether it's the patient comfort. And obviously, multi-modality imaging has to be used, and especially in the context of acoustic, I would say I'm often using cis sequence because it helps me in delineating the cochlea in a very nice manner. And of course, image guidance by means of floor-mounted X-rays, whether it's exact track or any other modalities, and CBCT-based imaging and surface-guided systems are there to guide us. Plethora of machines are there, as we know. And all of them essentially do the same job. What you need is established protocols, robust planning, stringent QA, IMRT, VMAT, ARC techniques, and probably a 6D couch. This is one of our patients which we treated. And you can see this was abutting the brain stem. And we planned this patient with multiple arcs. You can see non-coplanar arcs sparing the brain stem. And it was a bit of a challenging planning. And then after 3 months, you can see this very nice hypodensity that you can see inside. the area. So it was, and the patient was symptomatically also and had preservation of hearing. In fact, the hearing had become better than before. The upcoming advances as far as radiosurgery, cranial radiosurgery include proton SRS, flash SRS, biology-based SRS, AI-based SRS, but the final aim would be personalized SRS. What are the challenges? The controversies that we face and the challenges related to whether the patient should go for radiosurgery or surgery, they need to be sorted out. In radiation itself, we know that we are having inconsistency in RT fractionation schedules, the issue of dose volume constraints when we use different fractions. When we're using one fraction, obviously the dose volume constraint is going to be different. When we're using 5 fractions, it's going to be different. And then finalizing and this center to center, continent to continent variation in these constraints is a challenge. Long-term follow-up data needs to be reported. SRS is an important tool in high precision radiotherapy for vestibular schwannomas. It's critical to use image guidance. Frameless radiosurgery is becoming fast the standard of care. We should have and we should be cognizant about the sequelae of radiation as responsible radiation oncologists, and high precision SRS. Using this, we should aim to reduce these sequelae for our patients. Thank you all very much for patient hearing.